Good afternoon, everyone. Welcome to this meeting of the Health Overview and Scrutiny Committee on the 2nd of November, and which is taking place here in the Sparkling Hoe Committee Room, County Hall. Some of the officers are joining us online via Microsoft Teams, others are in the room with us. All of the county councillors who are part of the committee are here with us as well, and along with the lead member, Louise Richardson. So what we're going to do is start the meeting with the minutes of the last meeting, which was held on 31st of August. So I propose that the minutes of the meeting held on that date are taken as read, confirmed and signed. Is everyone happy with that? Okay. Sure. Well, we're just going, we will come to that bit in a couple of minutes, I think. So that's okay. Item 5. So hold on for 2 seconds. We're now on to item 2, which is question time. So haven't received any questions from the public. So that means on item 3, which questions asked by members under Standing Order 7375. Again, no questions from members. Item 4, to advise of any other items which the chairman has decided to take as urgent elsewhere on the agenda. Again, no items have been raised. So, Councillor Newton, we're now on to item 5, declarations of interest in respect of items on the agenda. If you want to do your
declarations of interest. My son and my daughter both work in the NHS. My daughter's is working out of here at the moment because she's clinical commissioning nurse.
Very much, Mrs. Newton. I think if you want to turn your button off as well. That's been turned on, you can turn it off. Okay, that's great. Any other declarations that anyone needs to make? Nope, I can't see any other hands raised. So we're on to item 6, declarations of party whip in accordance with overview scrutiny procedure 16. Are there any declarations of party whip? Can't see any. No, there aren't. Item 7, presentation of petitions under Standing Order 35. No petitions have been received. So we're now on to the main items of the meeting. We start with item 8, which is the Hinckley Community Diagnostic Centre and Day Case Project Update. So we have to help with this item. We've got Joanna Clinton, who's the Head of Strategy and Planning Integrated Care Board. There you are online. I can see you. Thank you very much. And also we've allowed David Bill, who's a county councillor here, to take part in the meeting as he represents the Hinckley area covered by the report. So David, I'll ask you at the appropriate point to say a few words as well. But we, as usual, take all reports as read. But Joanna, if I can ask you whether there's a sort of summary that you wish to talk us through, or any additional points that aren't in the report that maybe you wish to highlight. So over to you.
Thank you, Chair, and thank you for the introduction. So just a bit of a background for those folk that might not be aware of the project. So back in 2018, some NHS STP capital monies became available to make improvements for health services in Hinckley. And at that time, the NHS were looking to explore improvement, a refurb of the Hinckley Health Centre, the provision of endoscopy and day case services on the community hospital site, otherwise known as Sunnyside, which would have meant a removal of a ward to be able to facilitate those services on site. And the other thing that they were looking to do was to explore a possibility of a walk-in centre in Hinckley. Of course, then COVID hit, and it was necessary at that time for the NHS to pause the project because all of our efforts were, of course, focused on managing the pandemic. So in 2021, the project board was relaunched, and they took the opportunity to revisit the original plans in light of the learning of COVID. And at the time, the project board decided that we actually needed to concentrate on those existing services that were in need, and they were identified as endoscopy, X-ray and day case. And we also felt that actually we shouldn't remove that ward from the community hospital setting, because actually that was invaluable to the NHS during COVID, and actually is one of our most modern facilities across LLR. So at the same time, early sort of just shortly after we relaunched the project board, the National Community Diagnostic Centre programme was launched, and the ICB chose Hinckley as one of their preferred sites. So a business case was submitted, which actually included the endoscopy and X-ray services. And I'm pleased to say that actually since the report was written, we've received national approval. So that was given on the 22nd of October last month. So that's a total capital cost of 14.5 million. And that will be a modular build on the Hinckley District Hospital site. It will be completed in 2 phases, with phase 1 providing an MRI and CT scanner, plain film X-ray machine and ultrasound, and it will also include 2 phlebotomy rooms and 8 outpatient procedure rooms. And then in phase 2, there will be 2 endoscopy rooms with supported accommodation that's being developed, and that's due to complete at the end of 2023. So then for the STP capital, there was £7 million being made available, and that will provide all the current services that are currently being provided through the day case facility, but will include some other specialities like gynecology, urology, vascular, and there's a list in the report, so I won't go into too much detail about that. This is a 2-stage process that we have to undertake. So we're currently working on what's called an outline business case, and that's due to be submitted in March 23, and that has to receive national approval. Before then, we can submit our final business case, which again will be national approval. So all being well and it all goes smoothly and we get approved, we aim to be on site before March 24 with completion towards the end of 24, early 25. Really important to know, we know that there's been extensive engagement already that's been undertaken with regard to health improvements in Hinckley and Bosworth, and that won't go to waste. That absolutely will be taken into consideration in our future consultation. So the team are currently planning a 6-week public consultation to commence winter 22-23, and we'll work with a range of our partners, including the District Council and the voluntary community sector in that area. There'll be a range of opportunities for interested parties to participate both offline and online, and there's a whole list in the report, so quite extensive list. So I will stop there and I'm happy to take questions.
Thank you very much, Joanna. I can't see any. We've got a couple of hands raised, and then I'll come through to Mr. Bill. So, Mr. Harrison, do you want to go first, and then Dr. Hill's next?
Thank you. Good afternoon, and thank you for your introduction. I've got questions about how you process this business as you go forward, because I don't understand a short business case and then a longer, the more traditional one. Whereas in paragraph 10, I also spotted little bits that I thought, you know, the NHS is a specialist body, but the commercial side and how you process funding in an emergency, not an emergency, but it's urgent. Every business makes a decision, then it's urgent. They want to complete that. So that's normal business practice. But why is it taking so long to be able to go through all this process? And if you've defined a short form business case, is there not something that you could help speed up? Because the process seems very long-winded from when somebody said how many years ago we've got to do something to the time you actually walk in a building. And in modern business language, that wouldn't be acceptable. And obviously your case is probably urgent in many cases. So I'd really appreciate some more feedback on that. Thank you.
Am I okay to answer that?
No, please do, yes.
Yeah. So it's determined nationally to us. So it was at NHSE Department of Health that said for the Community Diagnostic Centre, due to the backlog of electives, that was a real urgent programme to get through. And so they developed a short form business case. So they tell us that's the process that you have to follow. So I've tried a couple of times to push back to our national colleagues to say, look, can we not use the same process for the STP capital? Because, you know, of just as you've said, how long it takes. But the answer has come back to say, no, you must use the traditional route. So it's not anything that's been determined locally. It's come down from the top to us, but completely agree.
Mr. Harrison,
Thank
you
you,
want
Mr.
to?
Chairman. No, I appreciate that. I understand that fully. But from a distance, it looks as though the value of those contracts are not so dissimilar. 14 million as a pitch and the first one at 7, whatever. You know, I just can't understand, because it's holding up process and it's making it worse. It's affecting people waiting to have treatments and investigations. Why on earth isn't there some urgency in this? Clearly the fund's allocated, so you're not sort of begging somebody, please, can I have some money? It's there. We just need them expediting quickly and smart on your feet, and surely the people you serve would benefit dramatically. Thank you, Mr. Chairman.
Do you want to come back on that point, or should we move on to the next question? You were nodding your head. I think you probably share the frustrations of Mr. Harrison.
Absolutely.
Okay. Dr. Hills, do you want to go next?
Perfect, thanks, Chair. I won't prolong the point, actually, because my first question was similar to what Dan was going to say in terms of timings. You know, I shared on Facebook on my council page the details of the CDC being approved and the funding being approved, and as you'd expect, everybody was incredibly happy. One of the comments though was, well, when is this going to happen? And in the press release that I read, like you said, it should be late 23 we're hoping for. But there will be a consultation happening at the end of this year, early next year. And, you know, there was sighs and moans from people commenting that haven't we had all these consultations before? You know, so similar to what Dan's point is, you know, I think we need to expedite the process a little bit if possible at all, or at least make sure that we're not delaying the process unnecessarily. But I think, like I said, we've already sort of discussed that issue. My second question is, it's absolutely fantastic we're having the CDC, the Community Diagnostic Centre, but what seems to be pushed into the long grass a little bit is this urgent care hub as well. Okay, we're going to discuss elsewhere on this agenda, you know, about the pressures in A&E. And I think these urgent care hubs are absolutely vital to improving the NHS system and taking pressures off other areas, reducing people going to A&E unnecessarily. People that can't get to their GP can go to them as well. So what assurances can you give that they're on the horizon, they are properly coming forward as quickly as possible?
So as I said in my introduction, at the time we needed to concentrate on those services that were most in need, and the financial envelope, you know, I need to take consideration of that. In terms of urgent care hub, I mean, primary care and out of our services has evolved quite a bit over the last few years, and there's much more services on offer. There is going to be an urgent care review, a system-wide review. And not to put Rachel on the spot, but I can see that she's in the room, and that actually sits with Rachel's team. I know there's been a delay to that because of winter, but Rachel, if you could give some sort of timescales to that.
Yeah, happily. So my name is Rachel Dewar. I'm the Associate Director for Urgent and Emergency Care across the system. So from an urgent care perspective, in terms of the urgent care hubs that we have plans for across Leicester, Leicestershire and Rutland, we've needed to think about things in a specific order. So we've had one of the biggest changes to primary care over recent months, and on the 1st of November we moved to enhanced access across primary care, which is probably the biggest change in primary care that we've had for at least a decade, I would say, and that has an ask around it for primary care to offer both booked and same day appointments over extended hours Monday to Friday and also on a Saturday. It's really important that we understand the impact of that in our planning for the urgent care hubs so that we can make sure that what we're
So Rachel, sorry, your mic has gone off. Apologies.
we're reviewing that over the next 3 months, and a plan will be pulled together from March to look at what our recommendations are for urgent care hubs following that point, once we understand that activity a little bit better.
Thank you. Apologies. They just for warning, one of those mics, and it may well be yours, Rachel, has a repeated sort of deciding to switch itself off. So if suddenly you hear your own voice go down in the room, then look to see if there's a red light. Apologies for that. Mr. Hills, or Dr. Hills rather, do you want to come back at all on that point, or you? Okay. Yeah, okay, thank you very much. Okay, we've got Mr. King, then we've got Mrs. Newton, and then once all the committee members are finished, then I'm going to ask Mr. Bill to come in as well. So, Mr. King, do you want to go next?
Yeah, so it's quite interesting in a way, this report, and it's also slightly concerning. Just to pick up a point that Mr. Harrison and Dr. Hills mentioned earlier. Now, according to the background report, which was considered in 2019, this has been going on since 2014. In fact, probably before that, I suspect. This is a spin out of the failed, when they built the new hospital at Hinckley in the early 2000s. And I was involved at that time with the project board at St. Luke's in Market Harborough. So I have a good knowledge of how slow and preponderous the process can be, unfortunately, as I'm sure the NHS people do. But I am a little bit concerned about this because we've got, at a previous meeting, Chair, we were told that in due course we would get a report about how community provision was going to be. There was going to be a review of community provision, and they were going to be looking at across LLR, how out in the county area particularly, how that provision was going to be put together. And then we were told, oh, we're going to do it piecemeal by piecemeal. And so what colleagues some of you will be aware of, there's currently a review undergoing at the moment in the Lutterworth locality, which isn't very far away from Hinckley. And I'm just wondering if those two things are related. But coming to what question I've got really, so in the report, it states that there was a new X-ray facility opened at Hinckley District Hospital, and then it says there's going to be a new X-ray facility in the CDC. So does that mean there'll be 2 X-ray facilities on site, plain X-ray facilities? And then the other question I've got is really about the amount of money that you've got allocated. Now, since this money was allocated in 2018, costs of construction have gone up considerably, a great deal, in fact, aside from inflation. And I'm just wondering if the amount of money you've actually got in your budget is actually sufficient to deliver what you say you want to deliver. And if not, are you going to be able to get the money from the NHS England capital pot, which isn't a large amount of money, I know, or is this something that you will have to go to the Treasury for to get additional money from, given that that's a very difficult financial situation for the Treasury at the moment, for the government at the moment? Are you likely to get, if there was a need for additional monies, are you likely to get this funding, given you haven't actually got the final business case approved yet? You've just got outline from what I understood was said. So I'm just wondering how firm this is actually going to be delivered, because we've kind of been here before with 1 or 2 other projects in the past, and then they've got pulled at the last minute because the government or the Treasury, whoever it is, hasn't agreed to put the money in because the costs have just escalated massively ahead of what the original business forecast was. And I'm just wondering if that is, that's a risk that is a degree of uncertainty about at the moment. Thank you, Chair.
Thank you. Joanna, do you want to come back on that one?
Yeah, so in answer to the first question, no, the X-ray will move into the new modular scheme. And then in terms of the cost, I presume it's referring to the day case, we've already done some preliminary work to make sure that the budget that we've got, 7 million, that we'll be able to provide day case. So we've done that piece of work, and that will form part of the submission to NHSE because we have to prove that it's affordable.
Okay, thank you very much. Okay, can I go to Mrs. Newton in that case?
Thank you. It's just a quick question. It's an item 2, create a new urgent care hub, providing out-of-hours care for patients. Can you give us some indication of what out-of-hours means in this situation? Thank you.
Joanna, do you want to come back on out of hours? What sort of hours are out of hours or considered to be out of hours?
So that just links to the conversation that Rachel has just provided an update on in terms of the out of hours provision that we have through extended access, but there's also an out of hours service provided from Hinckley for Derbyshire Health United. And I can't recall, sorry, Rachel, again, to put you on the spot, but the hours of that service, but that's an existing service. This isn't, it's not been included in these projects anymore because we needed to concentrate on the 3 services that were most in need, which were endoscopy, X-ray and day case.
Okay, so the enhanced access takes primary care up to 6 p.m. Monday to Friday, and the existing hub, which is in Hinckley, operates until 8 o'clock at night. Outside of that, the 24-hour service is the unscheduled is the urgent treatment centre at Loughborough, and also we've got a 24-hour service in the city of Merlin Vaz.
Final point, Mr. King, and then I'm going to go to Mr. Bill.
So when these, just my final question is about throughput. What sort of volume of patients are we actually talking about utilising? So in your business case, in your modelling that you've done, you've looked at the likely demand in the locality that will feed into this particular facility. What sort of throughput are we talking about that you're expecting to get through once it's fully open and operational? Could you give us some idea of the number of patients? And you just mentioned a point there about, you know, out of hours, 24 hours. Well, Hinckley to Loughborough is a long way for people if they're not very well. And that is a common occurrence about urgent care in the county. It's a long way to go if you can't access anything in the immediate locality. So I just wondered what the question, you know, the answer to that was. Thank you.
So I don't have the throughput figures on me at the moment. It was a different team that worked on the CDC, but I can provide that for you afterwards. And yes, absolutely agreed. From the information that we look at, a lot of people will access George Eliot and do access George Eliot for urgent care out of hours, and that'll be all stuff that Rachel will take into consideration when her team gets around to do the review. Thank you.
Okay, thanks, Don. Okay, so Ewan's going to pick up that last point following on, so we'll get the information back to you, Mr. King, and the rest of the committee. I think we've exhausted the committee questions. So, Mr. Bill, you're not part of this committee, but I know you are a local representative. So if you'd like to ask a question as well, that would be good.
Yes, thank you, Chairman, and thank you for giving me the opportunity to attend. And I'm really grateful to the members of the committee that have actually put most of the points I was going to ask. And so you've all been on the ball this afternoon, and well done. Yes, talking about the length of time, it's a quarter of a century since I was first involved with consultation over hospital improvements at Hinckley, and we've come to this point on several previous occasions where we've gone through consultation and engagement and then back to square one, and then it's a bit like Market Harbour really. We go around the circle and then we start again. Could I pick up the? Let's just understand it. So we're talking about £14 million for the CDC, which will then be followed hopefully by £7 million for the other services. So it's a £22 million programme altogether. That's That's how I read the report. Good, but it's all subject to the business case being approved by the NHS, and so we just got to hope that that happens. But could I pick up this point about the out of hours service? If it shuts at 6 o'clock, then that, I suppose this is really a question for Rachel. If it shuts at 6 o'clock, that is a problem for us in the urban area of Hinckley, Burbage, Earl Shilton and Barwell. What happens in practice is that when we have a medical emergency, we all head off for the George Eliot and join the 4-hour queue there at A&E. So what we really welcomed was the report back in December 2018, which said that there would be an urgent care hub in Hinckley, which I assume would be a 24-hour service. So we face a real problem now if where we're meant to be going is Loughborough, because it really is quite a cross-country trek from Hinckley. And so we prefer to do the 2 or 3 mile journey across the border into Warwickshire, where we attend the George Eliot in Nuneaton. Could I urge that serious consideration is given to putting that walk-in centre or minor injuries centre, what do you want to call it, into this proposal at Mount Road in Hinckley, because that is what is really needed for our local community. Thank you, Chairman.
So that's certainly something that's been scoped. It's not something that we've given absolute assurance about at the moment, because until we've done the work, we need to be really careful that actually what we're doing is putting the resources where the need is. So it's not something I can give assurance at. I think it would be really helpful to come back at a later date and have a more detailed conversation around the urgent treatment centres, urgent care hubs, and the work that's happening around that in more detail. And at that point, I will be able to bring a more detailed presentation. The reality for us, though, is as a system, LLR is a system surrounded by 6 other systems. So it is important that we work together in terms of kind of responsibility with the public purse and making sure that we have resources in the right place so that people can access the right care at the right time. And we're really cognizant of that. So we do, as a system, work with our other systems. So it wouldn't necessarily about being diverted to another emergency department if that wasn't your level of need, but another urgent care centre. So as we do our scoping, we are looking at not only what we have within our own system, but also what we have on the borders of our system and another system, and they are doing the same. So we will be working together. So I can't give any assurances about any 24-hour urgent care centre in Hinckley, but I can say that is part of the original scoping plan, and it is something that we will be exploring as we work through.
Okay, thank you very much for that, Rachel. And it may well be that we actually do bring, because I know that there will probably be some other discussion points later on about sort of access to centres rather than sort of everyone through A&E, etc. And obviously the conversations then about urgent care centres become quite critical, I suspect, to their success. So at some point it would be good to actually have that as a discussion point.
Yeah, and if I can just kind of make one more point, at the moment we're talking about a very small part of it. So in terms of our urgent care offer, we do need to remember we've also got the offer of our community pharmacies. We've also got a home visiting service. We've got a community urgent to our response. So there are a number of offers out there that we need to look at that whole spectrum of care and which of those services meet the different needs that our people have.
Okay, thank you very much. That's helpful. Okay, look, as Mr. Bill quite rightly said, there's some very good points raised on the paper, and thank you, Mr. Bill, for commenting on those. I think we've probably come to the end of that one. So, Joanna, thank you very much for joining us. Rachel, thank you very much for chipping in. I appreciate you've got your own item coming up. So we'll now move on to item 9, which is the LRR COVID-19. Thank you, Mr. Bill, as well for attending, which is the LRR COVID-19 and flu vaccination programme. We've got in the room with us Kay Darby, who's Deputy Director of Vaccination Programme. who will present the report. And as I said, we always take reports as read, but if there's anything summary-wise that you wish to point us towards or that you feel was worth highlighting, by all means, please do. Over to you.
I'll do. That's what I intended to do. So the paper effectively sets out for you the eligibility criteria for COVID and for flu this year, the delivery model. So just in terms of delivery model this year, you'll see we've got 59 sites delivering, but that kind of disguises the true network size. Since the previous programmes, there's been more flexibility in terms of vaccine movement. So what that does mean now is there is a greater range of vaccine delivered within all of our primary care practices. So there's 59 key sites where vaccine are delivered, but within those networks, primary care will be delivering within their existing practices as well. So the network is probably in the region of 3 times of that number at any kind of one time. And then what we have set out is the uptake, which was these reports pulled over a week ago. So in relation to I brought you some more up-to-date figures in terms of where we are from delivery. So the national campaign this year is aimed for 75% uptake, which is not significantly, but lower than previous campaigns. What we are seeing at the moment is our flu uptake is currently, as of last Thursday, 30%, which was a 6% increase from the previous week and what we've reported in the report. And the COVID vaccination rates are now 43.5%, which is an 11.2% increase on the previous week. What we are seeing, I think, for assurances, is the largest uptake is in the at-risk groups and the 65 plus groups. So we're doing fairly well on those groups. I think that's representative of the fact that the over 50s opened later. The over 50s only opened for flu from the 14th of October. So those figures for the over 50s are not included in the pack. What we are seeing is for the county, that while the average is 43.5%, the lowest uptake in the county is around by PCN area is 40, with the highest uptake being 50%. So I think at this point in time, we're expecting, I think, majority of the county to get there or thereabouts, 74-75%. A bit of a lag in the Charnwood area. But we are seeing significantly lower rates, I think, than we have done in previous campaigns. I think that's due to public appetite for uptake of vaccines, in terms of return to business as usual and less of a kind of willingness for people to come forward. The other thing that's not particularly covered in the report is we do have a contingency surge plan. So we are dusting down that surge plan in case we see any increase in COVID rates following Christmas, New Year. So that's kind of, we're good to push the button on that should that be needed and should JCVI decide that that's a national priority. The update is JCVI are considering whether there'll be a surge post-Christmas, are currently giving consideration to whether there's a spring campaign. We almost certainly know there'll be an autumn campaign next year, but the message is from a vaccination point of view, we're not into an annual booster yet, but because we know we're in 2023 steady state, so we're probably expecting to do a 6-month booster, particularly for those over 75s, as we did in 2022.
Okay, thank you very much for that, Kay. Can I open with a couple of questions about access? I mean, particularly around Charnwood, you mentioned lower figures. The area I live and represent is Charnwood. We have traditionally had lower uptakes in certain areas in Loughborough, and I know even through the main vaccine rollout in 2021, those areas lagged, and particularly where we had outbreaks, they mirrored almost exactly the areas where we had lower vaccination rates. And it's sort of slightly frustrating, I guess, that we're still seeing those lower vaccination rates, because actually it's something that we're well aware of through the NHS and also through partners. What more can be done to try and drive some of the vaccination rates in those areas? Because obviously it does have an effect, not only on those communities, but also then sort of roll out areas through passing on infections through where people are working, through care homes, etc., etc. So what more can be done to try and drive vaccination rates in some of those hard to reach areas?
it's very unfortunate because we work incredibly hard at this, and we've worked incredibly hard at it since the programme started in kind of December 21. I can see Mike nodding. We have got, in addition to the fixed sites, we've got 2 mobile vaccination units. So we work with public health colleagues. We meet with them every week to look at the uptake numbers by, and we've only recently got MSOA data for this campaign, but we know it's the usual MSOAs that have the lowest uptake. So we have got 2 mobile vehicles, and those vehicles will be taking the vaccine very much out into the communities. What we try to do with that is to link a campaign to it so that we can warm the population up before the mobile vaccination offer arrives, you know, to try to drive that uptake. So we're very much trying to work with community leaders, district councils. We've got very good relationships, I think, in the county with district councillors in terms of them supporting with kind of comms and getting the message out there in terms of uptake. But what we do know is that uptake does very much mirror the demographics of the area. So the higher deprived area is, the more minority ethnic groups in an area, we know traditionally there will be a lower uptake, and that's what we're constantly striving to address in terms of doing the community engagement and making the offer as convenient as possible. I think the shift this year is we are working with district councillors to identify where we've got the warm hubs. If we can do some messaging through the warm hubs, and if people don't have access to transport, we've already linked in with the council around free using the facilities you have in the county and in the city. So we're using some of your transport options out with the hours that you operate them to be able to bus people through the drive-through, which is around the corner. So we're kind of trying to work up and cover off all of the options around, you know, people with access in the local area, transport, sort of targeted approaches, you know, very much trying to use the district networks in the county.
Thank you. Mrs. Newton.
My question was a bit around that, but it's based on my own experience, basically. I went to my local chemist to book both flu and COVID, and he was no problem. Got the flu injection straight away, but he couldn't do COVID. And he said, you have to book that through the hospital, and which I did, but then they've given me a time that if people are travelling by public transport, they couldn't make it. I've got an evening appointment, and I just wondered whether that sort of timing militates against people actually getting their injections. And I was quite shocked that the chemist couldn't do COVID anymore, because that's where I got my original one. So I just wondered what is happening there in terms of people not being able to access the injections that they need. Thank you.
Yeah, we've got a network of community pharmacists that are delivering, but clearly nearly 100% of community pharmacists give flu. Not all of them give COVID. If your pharmacist previously given COVID, it's because during this round we are limited to an extent by the national logistics. So we can only have so many designated sites for vaccine delivery, because clearly it's run on a national level. So in terms of, we only have so may points of delivery. But I think we only lost 2 community pharmacies in this autumn round and gained some in other areas. So what we do in terms of capacity is try to make sure there's a spread of capacity across the area. So if we've got an over provision in one area, we will look to kind of bring some provision on, a substitute provision in an area that's underserved. So there is a little bit of switching around of sites. It's unfortunate your community pharmacy is the one that's no longer delivering. So I think we've only got 2 from spring that are no longer delivering this within the autumn campaign. But that's why we're working effectively with, there should be more than that community pharmacy in your area providing COVID. But if you want to contact me outside the meeting, we can see what the nearest centre is.
I think my concern really is, it isn't about my local chemist, it's the fact that people will not travel in by bus to go to the hospital to get their injections. I will, but my concern is the impact that will have on the take-up of the vaccine at this particular time coming into winter. I think that's, I really am concerned about that.
Yeah, and I think because of the economic crisis, that's why we're looking at, you know, trying to work with the warm hubs, provide free transport people through, you know, through the drive-through facility here and facilities that have got capacity, just to try to cover off all of those gaps. But if there are other specific initiatives that you're aware of, or problems in the county access-wise, if you feed them through to me, we're more than happy to look at those.
Okay, thank you very much. Mr. Charlesworth.
Thank you, Chair. Yeah, I'm just similar to Betty's point. I'm trying to understand the mechanics of it. I mean, I was at Two Steeples and I got a text saying I was entitled and ring in, and the missus actually got a phone call because she hasn't got a mobile phone. And that seemed to get everybody, that was for flu and the COVID jab. But I just wonder at Two Steeples, as an example, I mean, there are several surgeries within Two Steeples. Is it a different body of people organising these appointments, or is it the staff within the surgery that are doing it? That's my first question. Because are they contacting everybody for every GP practice within Wigston, or are they just operating out of particular surgeries, if you see what I mean? So are we covering the whole area? I think phone calls to make appointments are extremely effective because it then puts people on the spot. You know, people and ah about having the COVID more than the flu, I imagine. But if you're actually said, right, we've got these appointment dates available for you, would you like so and so? It's at that point you have to make a decision. If you really don't want the COVID, you're going to say no. But if you're thinking about it, you'll probably say yes. I mean, as a personal experience, I had the 3 first jabs with Pfizer. This recent one, the 4th one, was, what's the other one? Moderna. And I have to say, it was a dreadful experience. The arm hurt, but so what? But I felt really grotty for about 4 weeks after it. Now, I will go back if there's another booster available, but I imagine some people will say, I don't want to go through that again. And I don't know the experience of most people taking Moderna, but for me, it was pretty miserable. But I would go back for a booster, but I imagine some will say, never again. So really the question is the mechanics of how the surgeries are contacting everybody in the area.
I can't answer particularly for your PCN because it's a mixed bag across the county. So some PCNs will collaborate and they'll have just one central approach. So I live in North West Leicester, that's done. Everyone in North West Leicester gets a text, you click it, it's really quite easy. It offers you a number of clinics at 3-minute intervals. But some PCNs will do it on a surgery, practice by practice basis. So they don't all collaborate. So I can look into it and get back to you, but I couldn't tell you off the top of my head whether it's they're having a collaborative approach across all of the practices or whether it's the individual practice. But all of our GP surgeries are all opted in because they have a choice to opt into this or opt out of delivering COVID. So all of our PCNs are opted in. So all of the PCNs will be making direct contact with patients. So that's how effectively people will get booked. They'll either get text, calls from the surgery. We've got the national booking system, which is where you can book through the hospital hubs, book through community pharmacy. So unfortunately, at the minute, it is still a mixed economy of direct approach from your GP and members of the public going onto the national centre and finding a nearby centre, as well as we will advertise walk-in or turn up, no appointment services. So we still are in that kind of mixed economy. There's not one single booking system at the moment for the county, which does cause some confusion for the public, but it's kind of where we are in terms of development of the programme because it was set up so quickly 18 months ago. We're still kind of working through what the service is going to look like on a long-term basis.
Take up, you mentioned some places 50%, others 40%. Can we have that data at all? I mean, I know there was a real concern, especially with flu, about under 5s. They're being badly affected, I understand, and take up would be interesting.
Yeah, well, I'm quite happy. I mean, that data, that information is not in public domain, but I am quite happy to share it with you. So what I can prepare for you is a breakdown of COVID uptake by PCN area in the county, and we can give you a more detailed overview of the flu if you want that. We know we've got a couple of problemed areas with flu, so what we do is we do look at the data every week. We look at where we're at, and then we look at putting remedial actions in if we've got a particular area or a particular category where we're not seeing the uptake where we need it to be. But I'm quite happy to share that through the committee.
Okay, thank you very much. Mr. Harrison.
Thank you, Mr. Chairman. I'd like to know what sort of publicity that you're using to sort of attract people to this third or fourth range of injections. There's a lot of adverse publicity out there, and I only hear that. I'm not hearing how you're going to go about that adverse publicity, because people are vulnerable and a bit herdish, and if they, yeah, I've heard that, it's not whatever or whatever, you know, we can all have reactions, and they're not normally life-threatening, and after a day or two you're back to normal. But there is this thing that's in the media and out there continually, and it seems to be building up, because whether it's to sort of offset your efforts, but I don't see anything in the media about how important and how essential it is for that individual to go and say yes. They've sort of maligned it in a way that if you have it, you won't give it to anybody else. And so the evidence is proven that to be wrong. So they just pick a little bit and then, oh, that's it, that's the one to stop it. So I think personally, it'd be nice to be able to read positives about what's happening instead of all the negative that's out there in the media.
Yeah.
Thank you.
I think because COVID programme still is a national campaign, so all the comms come from the national team. So and what we do with that, we get national materials that we distribute locally, and then also we have targeted local campaigns where we know we've got an uptake issue. Does that make sense? So we try to bespoke what the national offer is. Yeah, it's interesting whether people see things or not. I mean, personally, because I work from home now, I've seen quite a lot of COVID this year on. We're still getting quite a lot of media coverage. You know, we've had site visits recently. We had some filming at the drive-through. We've also had some filming at the Melton Centre, I think, in this campaign. So we do periodically, we push constantly to try to get the Leicestershire sort of offer out there on, you know, East Midlands Today and kind of on the local channels, as well as trying to promote the national campaign as well. What you won't see is some of it is quite targeted. So where we know we have an issue with uptake in pregnancy, the adverts on TV are targeted to the intervals where, you know, that demographic will be watching TV. So somebody such as yourself may not see that, same as, you know, I may not see that, but it's a targeted approach. So a targeted approach to catch kind of younger people, for example, in previous campaigns, pregnant ladies, and they tend to be linked, as you know, when you've got kind of programmes that appeal to that demographic, you'll see the nappy adverts, the thing, and then the COVID advert for pregnancy. So that's why some of it's not always visible, because it tends to be targeted rather than generalised.
Can I bring in Mike Sandys at the moment, because I know he wants to mention something on this as well.
All right, that's better. Hey, just, well, not to leap to your defence, but I suppose there is a bit in terms of targeted campaigns. You are doing this on less money than last year as well, isn't it? I mean, you know, is it about half the budget overall, not just comms, but the whole campaign? Is that about right? I
think it's probably 30% of what we had last year. So I think we were in a very fortunate position because we were under kind of emergency measures. We had a blank checkbook. So as you know, the programme set off a pace, didn't it? And we kind of mobilised very rapidly and learnt very rapidly. We are actually moved into a fixed allocation now. So that allocation set nationally pro rata. So we get a pro rata allocation for the programme costs, such as myself, the actual delivery vehicle, and an enhancement for accessing inequalities. So that's done on a demographic basis in terms of weighted towards deprivation, ethnicity, age profile, because we know, you know, cities such as Birmingham, where they have a strong profile of young people, the uptake tends to be lower as well. So yeah, we are running on a fixed budget this year. The ICB are subsidising the fixed budget this year. We can't actually run what we feel is a comprehensive programme on the national allocation. So we, Andy Williams and the exec team and the system have supported that we will probably run at an overcost this year. So we are putting, the ICB is putting more investment into the COVID campaign than actually what is flowing down nationally.
Thanks. And I guess also it's quite difficult sometimes overcoming. I mean, you know, the thing about social media in particular is that people choose their own channels, so they choose who to follow, they choose the groups that they follow, and you know, I mean, Mr. Harrison, I think is right that unfortunately some of those have become vehemently anti-vaccination, and that's now sort of bleeding across the GB News and various other sort of news outlets who are increasingly becoming difficult to actually be able to transmit sort of positive news about the benefits of vaccination. And you know, we all, I think, probably, as I know Mr. Harrison has said, you know, increasingly have to put across, you know, this is actually for people's benefit, and for all of our benefit to actually get the messaging across. Because from what you've just said and from what Mike just outlined, budgets are limited, and we haven't got the sort of blanket wall-to-wall coverage that we've had in the last couple of years to try and actually get those messages across, and particularly on flu, where, you know, we have not had the urgency, I think, in probably the last couple of years, whereas clearly that is a concern this year. Mike, do you want to come back on that? Sorry.
Yeah, thank you. So, and if we're heading towards the end, I suppose that's the key point. I think, as Mr. Charlesworth, you said about, you know, the message is out there that doesn't stop you contracting it. Also, Mr. Harrison, it might have been you, I forget. But I suppose that's the key bit, isn't it? That understanding now for me is growing that vaccination won't necessarily stop transmission, but at the end of the day, it will stop you dying or contracting serious illness. So that bit shouldn't need a publicity campaign, because we don't do that for any other real, you know, vaccination campaign. It's taken as read. We know the benefit of vaccination. So really the targeted stuff, partly finance, but really that should just be on relying on the population to know what's the best thing to do, and then working with those parts of the community that don't. But you know, it all seems to me to be the fairly basic core message. It will save your life still.
Okay, thank you very much. Okay, can't see any further questions, so thank you very much, Kay, for that, and also for Mike for his comments as well. If we could have the data that you talked about, Kay, that would be quite helpful, and also likewise, obviously through all of our social media and channels that we can, we'll obviously still try and support the campaigns, limited or otherwise, that the county and national are running on flu and the COVID vaccinations. So thank you very much. Okay, we'll now move on to item 10, which is the planning for a resilient winter across, which is very much a sort of follow-on point, resilient winter across the LRR health and care system. John Melbourne, thank you very much for coming back, Chief Operating Officer at the University Hospitals of Leicester, and also joined by Rachel, of course, who we've heard from slightly earlier on. Now, Rachel's obviously from the ICB, and it's a combined report. So again, obviously we'll take any reports as read, but if there are any particular points that you want to tease out, then please do so.
Thank you very much. I'll begin. So I'm John. Thank you for the introduction again. And thank you for having me again. Rachna Bias sends her apologies today. She had hoped to come, but there was a late change, which meant she couldn't come along. So sincere apologies from Rachna. So what I'd like to provide a summary of today, and further to our meeting a month or two ago, is a little bit more detail behind our plans for winter and some of the challenges we're facing. And of course, it'd be good to take any questions which you might have. It is fair to say, from a context perspective, we remain incredibly challenged as a health and care system, not just within UHL, but across the system as well. I think that's reflected within the plan which we present in the paper today. What we've we are focusing on many things across the system. What we've presented here are the 20 key actions which we think will have the biggest impact this winter, noting that many of them we will want to carry on into next year, but some of them we won't actually. Some of them are things which we think we need to put in place for this winter, and we hope not to be relying on next winter. Just to pick out a few of those, and again, much like last time, we focused on flow into the hospital, i.e. what we call our primary care collaborative, so care outside of the hospital, flow through our hospital, and then flow out of our hospital. And that's the way we've split up our governance structure in what we call the primary care collaborative, the acute care collaborative, and the home first collaborative, that being the flow in, flow through, and flow out links. So I'll start briefly with the primary care collaborative. A couple of the key initiatives there we've already touched upon. One is around expanding our urgent treatment centre offering outside of the hospital. We are planning to put more appointments in, and specifically ring fence some appointments for our emergency department to book into. We know we have people coming to our emergency department who don't need to access it, but we know they're also struggling to access care elsewhere in the county and elsewhere. It is fair to say, again, we have one of the biggest EDs and emergency departments in the country. We are doing everything we can to make sure that the people that need to be there get treated swiftly, but also that the right people attend that department. We have over 800 people a day on average attending our emergency department at the LRI. And we know again that there are proportionally more people accessing our emergency department from the city as opposed to the county for many reasons, which I'm happy to get into some of the reasons behind that in a moment. But again, I'll come to later on some of that assuring equity and equality and access to our healthcare across the system is really fundamental in our plan. The second point is the primary care interface. What we're trying to do is provide in-reach and advice into primary care, which means that people don't have to present to our emergency department or don't have to be sent into the emergency department. And so more phone advice, more advice and guidance, and lots more alongside that is a really fundamental part of our plan this winter. Moving on to acute care, which is basically the in-hospital side of things. We are opening additional capacity. I say in-hospital, but the when you need acute care side of things. So we've opened a care home as UHL, the Ashton Care Home. We are opening it. We have opened additional community beds. We've opened additional acute beds at UHL as well, essentially to try and create additional capacity so that the bed shortage that we see on a day-to-day basis is minimised. Alongside that, we know that we can do more internally to make sure we have really slick flow through the organisation. It is fair to say we have people awaiting in our emergency department for a bed in our organisation. We know when we get that flow from our emergency department into beds, we don't have an issue with ambulance handovers and we have shorter waits within ED. So that point around capacity and process within the organisation is fundamental. From a process perspective, I know there was a question about what is referenced in here as the North Bristol model, what we call the rapid flow model. What this is about is fundamentally making sure that flow through our organisation is really slick. So to give an example, if somebody leaves to go home or to go to a care home from our hospital, if we're running a slow process, you might have a scenario where they leave, their bed space is cleaned, then the patient is called for, they will go into that space and you might end up with an hour or two gaps there, which is really fundamental when you're trying to run an urgent emergency care service. So rapid flow is essentially trying to match movement of patients to expected discharge. So you call for a patient in advance of a discharge going on the expectation that somebody's gone out by the time they've arrived at a ward or an assessment area or elsewhere. And of course, there are risks around this. The risks are that sometimes people will arrive on a ward and the other person hasn't gone. We're very carefully managing this. We look at every single, what we call our datics, which is incidents where things like this happen. It can improve flow, but it can have that risk. And we recognise that we are working in an environment of risk at the moment, significant risk in some areas, and we think this is a really important model to equalise that risk through our hospital and through the system because of that risk which is presenting in our emergency department and indeed in East Midlands Ambulance Service at times. And then the third point is around getting people out of hospital or home first. So we are recruiting to large numbers of people in our Pathway 1, which is to support people to have care in their home. It is fair to say we are struggling to recruit in some areas there, and our council partners are struggling for many reasons linked to that. We know there are real recruitment challenges across the piece, but we have put a lot of funding into that, and we're out to advert across the system, across Leicester, Leicestershire and Rutland now. We're also increasing our Pathway 2 capacity, which is essentially care homes. And we're also increasing what we're calling virtual wards, which is again to support people medically in their homes. So a good example of this is we have many patients at the Glenfield Hospital who will present with cardiac problems or heart problems. And previously they've had to sit in a bed and be monitored for a week. Now we can monitor them remotely. They test at various times in the day, and it means they can stay at home, but they have access to the exact same diagnostics and treatment diagnostics as they would have before. And if anything goes wrong, immediately they can come in. That's been incredibly positive, A, in terms of freeing up capacity, and B, in terms of patient experience. So there's some of the key initiatives. There's many more within there. I'm very happy to go into detail of all of them. I think the fundamental point for me is we are trying to act rapidly across all aspects of health and social care provision. What we present, we think, is a very ambitious plan for winter. I was at a national meeting yesterday with all of our acute trusts. I don't believe that anyone was presenting a more ambitious plan than us. That said, I also acknowledge it is not enough. We need to do more as a system, and we need to do more as a health and social care system to address some of the challenges we're facing, both on emergency care and planned care. And we absolutely acknowledge that, and we will do everything we can to continue to grow and develop this plan. My final point, forgive me, is alongside all of this, we will not lose focus of the inequalities agenda. So we're carefully looking at differential access that we're seeing in the system, and we're targeting interventions alongside that, both for planned and emergency care, to make sure that people get the right care equally across our communities. For example, our comms agenda, our comms plan for winter will come in multiple different languages to make sure that people understand where they can access care. We have a long way to go on that as well, and we acknowledge it, but we are making progress.
Thank you very much for that, John. We've got lots of hands going up. I'm going to be very cheeky and ask for the first question. You've set out the 6 national metrics that are going to be sort of judged as to whether or not you're getting through the winter. Would you add any others locally? I mean, are there any others that you think for UHL in particular, and also for the LR area, are just as critical as those 6 that are the national ones?
So I think the 6 national ones are the right metrics to measure our overall urgent and emergency care performance, and that's what we have said. However, to deliver that, we have metrics against each of our individual interventions that we will make sure that we measure the success of. So, for example, we'll have discharge metrics, we'll have metrics against occupancy of additional capacity, we'll have metrics against our rapid flow. So the way we work is we've got the, let's call it the umbrella metrics of those 6, and then individual metrics of every single scheme with an accountable lead for each scheme.
Again, would it be a case that any one of those set off alarm bells if they start to fail? I mean, which is the trigger that you really are not looking forward to seeing?
The fundamental trigger for me is the ambulance handover position at the moment. That's our first step, is let's get the ambulances inside the hospital, and then let's reduce the time that we're having people waiting in our emergency department.
We will look out for that one in that case. Okay, are you going to do an arm wrestle? Whose hand went up first between Mr. Harrison? Okay. Sorry, Mrs. Newton, were you first? In which case, Mr. Harrison, if you're a gentleman, it's Mrs. Newton first. Mrs. Newton. Oh, okay, Mr. Harrison and then Mrs. Newton.
Able to get this, back that up with the best I make. Because I just don't quite.
Yes, you wanted the number of job vacancies across the urgent and emergency system.
Oh, it's going off. Gosh, they're all going off now, Mr. Chairman. Sorry about that. I was on the bed blocking, which is absolutely serious, because when I went to meet the chief exec of the ambulance service, I can't remember, the previous month was like 16 or 17,000 hours that they'd lost. It was just a colossal figure. Please don't quote me on that. It was a huge number. I just don't have the exactness to mind at the moment. And it seemed incredible, because that has a big effect as their first line. They're meeting people and picking people up. So whatever you're doing now to try to make access speedier regarding ambulance, I think that's fantastic. To what level it'll have an impact, wait and see. At your response and statistics, but I wish you well on it, because I think that these are the initiatives. We've got to find ways quickly to be able, because the whole thing's blocked. They can't go out, and they're the first responders before we even get to you. And if they're sort of queuing up outside with people in their ambulances, it's not very helpful. So very pleased to hear that. I don't understand the virtual wards, and scaling up of virtual wards is on your document of your 8. If you could sort of expand that a little bit more for me. Thank you.
Thank you very much. Just to pick on 3 points. So firstly, the data request, you're right, you kindly reminded Rachna and I about it last week. I'm sorry it wasn't with you before now, and I know Rachna is as well. My understanding is that Rachna has sent the vacancies data through to you and or to somebody. Right here. So no. So let me be very clear. I'm not saying that Ewan's got it. What I am saying is that Rachna told me it was done. So I will pick up with Rachna immediately after this meeting and get that sorted. What I can tell you right now is, as a trust, we have a 12% vacancy rate at the moment in our ED and emergency department and assessment areas. We're offering a 13% vacancy rate across all of our professions. We do have that breakdown with all of our services across our 17,000 colleagues. Every single month we have performance review meetings with them, and we go through vacancy rates and we target interventions where we have significant. So as a trust, I can promise you it is top of our workforce, is absolutely top of our radar. And as a trust, as I say, a 12% vacancy rate. We have the system vacancy rates as well, which is why Rachna's provided it. I'm really sorry, Ewan, that it's not with you before now. You can perhaps see my frustration now. I'll make sure that's sorted.
Thank you, Mr. Chairman. So it's a large number. It's a big number, isn't it, really, on vacancies? What programme have you got that you're building on to try to alleviate that and obviously get the right sort of return on it?
Yeah, so you are absolutely right. It is a big number. Sadly, it's not dissimilar to a lot of NHS trusts across the UK, and some of it's natural turnover. So people will turn over in jobs, you'll end up with a gap, etc. So I'm not going to suggest that whole 12% is a problem per se, and we will cover with bank and agency, etc., which is essentially temporary cover. But I think I said last time, what we know is that we need to be a better employer so that people want to come and work for us. We're also working with national and regional partners to create education programs and the university, etc., to retain. We want to be a place where people want to come, but also people want to stay. And we absolutely acknowledge that. Just before I came here, we were talking to our leadership team across the trust of 200 people, specifically around our offer as a trust and how we can create it, make it a better place to work and a better place to stay and be developed. A good example of that is literally today we have launched what we call the Locums Nest, which is a way for our junior doctors to get access to short-term shifts and get paid more swiftly than we have been able to offer previously. This is seen as a hugely positive step forward. Our workforce leads said they got a round of applause from the junior doctors leaving the room. We're trying to make initiatives like that will make an actual difference to people's working life and experience, and will want to stay in Leicestershire.
I can't imagine who came up with the Nest proposal. It says, I'm trying to imagine the conversation, but
digital branding.
Okay, I accept that one. Mrs. Newson, do you want to go next?
Sorry about that. I really wanted to ask a question about fuel poverty, because you've got down one of the tasks is to implement fuel poverty. Going off again, sorry. Older people very rarely will come forward and say they have a problem because they're so proud and that they like to think that they can manage. So my question really is, how are you going to reach out? Who do you know to reach out to? How do you reach out to them? And what will you do in terms of the fuel poverty plan to assist them throughout the winter? Thank you.
Yeah, so the fuel poverty work is happening all the way across the health and care system, and so we have a system called Making Every Contact Count, where anybody who enters the home of any patient, whether that's a health service, a social care service, or police, fire, take note of the environment that the individual is living in. So making every contact count is a really important element and part of this. So if people are entering houses and they're noticing that houses are cold, for example, we will be working with those individuals and making sure that that is noticed. It's a really tricky thing to do because we can't fix the situation, but what we can do is kind of make sure that our most vulnerable people are noticed and acknowledged. So our GP registers, we know who our people with serious mental illness are who live in our communities. We know who our people who are frail are. We know people who have got respiratory infections or chronic diseases. So we will be working with those most vulnerable groups and making sure that we do some proactive work with those people in terms of how they look after themselves and keep each other safe, keep themselves safe and warm, as well as a more broader campaign around winter fuel resilience and safety.
Back. I remember once doing a bit of research, and one chap said to me he suffered from the most common disease in the world, and I asked him what it was, and he says loneliness, and it's never left me, that comment. And he was an older man, but he didn't reach out for help, and this is the problem. How do you reach out and help those people who are too proud to say that they need help? And they're the people really at times that need the most help of all. Thank you.
And I suppose just to jump in on that one, that comes back to some of the work across local authority, ourselves in the NHS around local area coordination and social prescribing. So I know it's not quite where we're at, but actually what's in place through the community anyway has been a really important part of how we do the outreach work.
Thank you very much. Thank you very much, Ms. Newton. Okay, Dr. Hills.
Thank you, Chair. I want to start by thanking you for the report. If we go back to the last meeting we had about the CQC inspection, and there's a little bit of frustration among committee members that whilst the problems were identified and it said they'd get fixed, it wasn't very specific on how that would happen. And we touched on kind of recruitment issues. This report is a much more pleasurable read and reassuring because it's slit down into key deliverables, actions. What is the impact going to be? Who is accountable? What is the timescale? It's a lot more reassuring to see, the plan on the paper. So John, because you're here, I'll give you the credit for that. But I think Rachel actually wrote it, did she? Or did the presentation? But I mean, it's a team effort, so thank you for that. Mine's more of a general question, actually. We've spoken about these 6 key metrics. More differently, what do you think the barriers to implementing this plan successfully will be? And what keeps you up at night with delivering the plan?
Thank you. And yes, Rachel and Rachel get all the credit, to be clear. And again, that's our misunderstanding. Next time we won't make that mistake. So we had this plan last time, we didn't share it, and my apologies for that. So all of it keeps me up at night, and I guess this is we have clear plans. They are also risky, and also to give an example, recently we had a 3-day period where we had 150 more admissions than discharges. Those type of days, they are very difficult to handle. Those type of spells, and so that level of variation when we're running urgent and emergency care is risky. And so yeah, absolutely, that's why we're on the 9:30 calls every evening to try and help through this process and support our colleagues through it. What's my biggest concern about it? So fundamentally, my biggest concern in terms of delivery is workforce. To be able to staff these initiatives. And I think if we had the colleagues that could run all of these initiatives right now, I think we'd be in a really strong position as a system. But workforce is a real challenge across everywhere. And I include both numbers and morale in that, which is why we need to focus on both sides of it. And if you talk about my fundamental concern outside of that, it's health and safety of our patients across the communities. Like has been explained, there are a lot of people in very challenging situations at the minute that are both presenting and having to wait too long for their care, and who are not presenting. And both of those are real concerns for us, which is why we've got to focus on all aspects of this. And equally, we've got to focus on planned care as well, because we could easily turn off planned care and say, right, urgent emergency care is running okay today, but that would just make everything worse in the future. And so we've got to keep that balance, and we're trying to also ring fence our elective care to keep things going to that end as well. So forgive me if that's quite a circuitous answer, but workforce would be the number one. I also, sorry, just to add to the point earlier on, we are working with the voluntary sector as well. So we had a meeting with Age Concern recently about coming into our hospital and getting a stand and a position to speak to patients about what support they need. And they're being very supportive, and we'll do everything we can working with partners across the system, because we won't be able to do this alone. We're very clear on that.
Thank you very much. And I think we're through the questions. So look, thank you very much, John. And Mr. King, you didn't have your hand up, did you? You did. You weren't waving at me. I look over there and all I see is Mr. Harrison. I never see you. Okay, Mr. King, go for it.
Thank you, Chairman. Thank you for the report. And just some of the stuff I was going to ask you about has been said. Well, quite a lot of it actually. But I had got one question for you. So you mentioned earlier, and at the previous meeting which you came to, you talked about the ambulance waiting time, and that's clearly a very obvious and upfront demonstrable thing that people or ambulances are waiting outside the the doors of ER. You know about it, and if you're in one of those ambulances, you know about it. So whilst it is pleasing to see that the numbers of ambulances waiting over 30 minutes have gone down in the report, and that's good, it's still a very considerable number of ambulances waiting over half an hour. And obviously you haven't got into all the detail of whether they've been waiting 2, 3, 4, 8, 10, 20 or however long it is, but it is nonetheless still a considerable number. And really, I think, listening to what others have said, I think, it's quite simple in a way, isn't it? At the end of the day, you're trying to reduce the input, the people coming in, essentially, and get the number going out one way or the other to increase. It's basically it's a throughput. And when you came to the last meeting, you did explain that very well, actually. And so what I'm a little bit concerned about in what I've heard is what the role of primary care is here, because experience of many people still in Leicestershire about primary care is not as positive as it could be or ought to be by now. There's still, I think, too many instances of patients being turned away by GPs or other gatekeepers, and I'm concerned about that. There's still the mad 8 o'clock or 8:30 dash on the telephone to get through, to get an appointment. And there are colleagues who I've spoken to very recently in the last couple of weeks who've had that experience and been told, well, you can't have an appointment today, you'll have to ring up tomorrow. And that's not, and then they've then resorted, to then other routes to get access to care, and that's 111, or then turning up at an urgent care centre. Well, that's not really, that shouldn't be happening, because they should have been able to get access to primary care because it's not really an urgent thing, but because they're concerned about their issue, they're pitching up. And I'm wondering what's really happening to kind of prevent people turning up at the walk-ins at A&E at the Royal, because obviously that's open 24/7, and essentially you can't stop anyone coming in. And that, I think, is one of the fundamental problems you've still got if you can't sort out the kind of outer ring of Leicestershire and people stopping, well, nowhere's open. So what in this plan is going to address that? Because that's, I think, a much more fundamental problem that doesn't help when it comes to the winter. But there's nothing new about this. This is problem's been here a long time. May not be peculiar to Leicestershire, but I think it's the same in many other places. But what are you doing to address that?
Thank you. I'll let Rachel come in, but just to say, first of all, what we're presenting today is a plan. To be absolutely clear, we do not accept the level of performance we are seeing in terms of ambulance handovers and waits for patients in Leicester, Leicestershire and Rutland. We are saying that we absolutely will do everything we can to improve that, and that is our number one aim. We know the level of performance we have at the minute is not an acceptable position to be in.
Yeah, so specifically around primary care, there is a report called the Fuller Report which was carried out into primary care services, which has a number of actions against it, which we are working through across our system. One of the most important elements of that is looking at variation in primary care. And what that enables us to do is to work really closely with individual GP practices or GP practices within a primary care network. If they are making additional referrals, or if there is lower access or lower number of appointments within particular areas, then we can work with those practices to find out where. And we also now have an information stream coming out of the emergency department as well, and they will report to us where they have concerns around patients from particular GP practices who are attending. So we're working at that in real time. We're also looking really closely at that activity as part of the enhanced access. So we're expecting the enhanced access to mean that more patients are being seen within that primary care arena and fewer people are being bounced away. So that's also really helpful for us. And we've also got a validation service as part of our triage that follows 111 to make sure that referrals that are coming in following an attempted access to primary care routes those people back to booked appointments and the appointments that the 111 and the navigation service can access. So there's a huge amount of work happening around that. It's worth mentioning the other piece of work that we've got that is listed here is around the unscheduled care coordination hub, and I think it's really important that I kind of finish on a bit of a positive. So the unscheduled care coordination hub has colleagues from East Midlands Ambulance Service, from our community providers, from the Clinical Navigation Hub, and from a number of different services. And what they're doing is they're looking at the ambulance stack. So they're looking at patients who are waiting for an ambulance to be dispatched to them. And roughly 40 to 50 patients a day are taken from that stack, and another service is sent out to support those patients, which means that whilst it isn't solving the problems of ambulances queuing outside ED, the other work we are doing is focusing on that. What it is meaning is there's fewer patients waiting for those ambulances, and the patients that are waiting for those ambulances are the ones who absolutely need them. So it's kind of a circular attack really on the problem within the system, and just looking at one part of it won't fix it. But actually in the round, the work that we are doing and working with individual practices, which is around clinical navigation, getting people to the right place first, we can see that starting to have an impact.
Actually, just to follow on that, Ewan's just reminded me that we actually have for the next meeting subject on primary care and the fuller report. So we'll be able to cover that in a lot more detail. So good timing. Okay.
Thank you.
Thank you very much. Okay, look, no more questions. I'm looking around the room just in case I've missed anyone else apart from Mr. King. I don't think so. So thank you very much for your answers and presentation, Rachel, and also John. Good luck with the 6 metrics. We will be thinking of you lying awake at night. We will probably also be lying awake at night as well, but thank you very much and good luck. And we look forward to seeing you back in hopefully the new year with confirmation that it's been a success and your plan has worked, and we've got through the winter period. So thank you very much. No pressure at all. No pressure at all. Thank you. Okay, we're now on to the final item of the meeting, which is item 11, health performance update. Approaching the desks, we have Andy Brown, who's team leader, business intelligence at the County Council, and also Hannah Hutchinson, who's assistant director of performance and quality improvement, get my teeth in, integrated care board again. So welcome to both of you. We will ignore the name boards that are currently there in front of you, otherwise we'll be calling you Rachel and Kay by accident. So very good to see you both. Thank you very much. As always, we take reports as read, but by all means have an opportunity just to say a few words about any particular items that you wish to pull out from the report that you've given us and that we've read before we go into questions.
Okay, thank you, Chair. Just a few introductory comments. The report before you today is the regular performance and overview report that comes to the committee based on data at the 30th of September, which is the latest full set of data that we had. We've looked to streamline the report a little bit this time because we were conscious we were getting reams of data. So we bought a set of 38 more targeted public health metrics rather than the full set of health and wellbeing strategy metrics. But we're very keen to hear the committee's views on the coverage of the report. If there's extra things you'd like to see, keen to take those on board. Hannah's here today covering for Kate Allardyce. Kate's fed in a lot of the data in the central section of the report. I don't know whether you want to pick out any particular points from the middle section.
Yeah, thank you very much. So a number of the performance indicators that we're reporting on currently are at system level, so cover the whole of Leicester, Leicestershire and Rutland. And what we've tried to do through this report is pull out the indicators for Leicestershire, but they do include Rutland. It's still the way that a number of the health indicators are set up because they're based historically on clinical commissioning group areas. So apologies for that. And one of the things, again, just to follow on, we were thinking it would be helpful for the committee to review is we're really conscious that you've got a number of health metrics within the county place-based plan as part of your 10-year strategy. And would you find it more helpful to have reporting against those coming here in due course rather than some of the indicators that we've currently got? But what we've tried to do is pull out some of the key indicators here based around the NHS system oversight framework. We have around 60 indicators at the moment that are in the oversight framework, and an update of the full pack hasn't actually been available now for a number of months, but we are kind of looking at some of the key crucial areas. I think it's just worth saying there are still challenges since COVID within the NHS, and I think some of these health indicators reflect that at the moment. 62-day for cancer, for example, we're standing at performance around 58% against a target of 85%. But it's worth saying that we have had an improvement in patients being seen within the 2 weeks. We had a huge increase in the number of patients being referred in from primary care for 2-week wait appointments, and that has actually improved. And again, the 28-day faster diagnosis standard has also improved. So the first part of the pathway, we're starting to really note that improvement, which is worth seeing, and that's recorded in paragraph 17. I know that you've just had a huge presentation around winter plan, etc. So I won't kind of spend too long dwelling on A&E and some of the challenges there, but it's worth saying that for a number of the different trusts that the patients go to in Leicestershire County, we're seeing very similar sorts of challenges, whether it's UHL or Coventry and Warwick or George Eliot, for example. They're all struggling against the 4-hour A&E target. Again, we, in terms of the 104-week waits, we know that obviously that's had a really prominent attention in the media and politically as well. And that's been something we've been working really hard at through the elective care work. To see coming down, and it absolutely is coming down month on month, which is very encouraging. So 104-week waits for county council patients are Leicestershire County patients, sorry, is 172, and 136 of them currently are within UHL. So UHL are also finding that their lists are coming down, but they started much, much higher than most of the other acute trusts in our neighbouring patch. Dementia, I will just pull out as one area, and then I can pause and hand back. So dementia, the dementia diagnosis rate, the national target is 66.7%. And here we're standing at 58.6%, but you'll see there is quite a disparity between the east and the west of Leicestershire. That's something that we are picking up at the moment, and we're looking at why those weights are increasing. So we know at the moment we've got across the whole of Leicester, Leicestershire and Rutland quite a high number of patients who are waiting for memory assessment clinics. And is there any correlation between that and the dementia diagnosis rates that we're seeing coming through? And that's something that our system quality group are looking into as well, and getting regular updates from our mental health group to make sure that we're not losing some of that. We were doing really quite well against that indicator, so that's one of the things that's coming down. But I will pause there and either hand back or open it up to questions as ever you would like. Thank you.
Just two further points just on the second half of the report. I'll take it largely as read, but interesting in paragraph 21 around life expectancy for the committee to note that Leicestershire does well compared with other areas, but along with nationally, there's been a reduction in life expectancy at birth, decreased by 0.4 years for males, 0.3 years for females. I wonder if it's starting to pick up the COVID data, 18 to 20, that reflects through that. We've got Victoria Rice on the call who'll pop up in the background if there's any technical questions around that. And also healthy life expectancy. Decreased by 0.6 years for males, so interesting in paragraph 21. And then the final paragraph around the BCF, these are for 2021 metrics. There's a new plan being metrics. 2 of them were met, so that was really good news. Reablement has been performing well, and unplanned admissions for chronic ambulatory and sensitive conditions, which is the focus for the BCF. Those 2 were met. The other 3 areas were slightly under the targets, partly demand coming back into the system post-COVID. So there were more admissions into residential nursing care homes, not quite hitting the length of stay in hospital for 14 and 21-day target. And similarly, the percentage of people discharged home, really due to the extra demand that came back into the system, but still priorities and work going on around that for the BCF.
Okay. Thank you very much. Apologies for the microphones. We do seem to have some faulty microphones, I think, at that end of the room, so apologies. So, okay. I can see Mr. King's hand up first. So, Mike, did you want to come in first before passing on to Mr. King?
Yeah, it's partly a question as well as a comment, though, so if you don't mind. Just on COVID, that's what I was thinking, Andy. It looks to me as if it's the first year, 2020 will be the first year, obviously, that COVID deaths will start kicking in. The bit for me is, I mean, it is a stark reminder of the difference that COVID makes, because I can't think of any other time in the last God knows how many years that life expectancy has gone backwards instead of increasing. The point for me is, I suppose, is comparatively, and I haven't got the figures to hand, but I was wondering if Victoria did. I think somewhere like the city, the reduction in life expectancy has been nearer kind of 2 years, as opposed to our kind of 0.4 and 0.3. So as always, there's an absolute sense of look what difference it made, but a relative sense of I don't want to say we came out of it relatively well, but I think that's what I do mean.
I can see Victoria desperately looking at a screen at the moment, looking for the stat. Yeah. Okay, so as soon as she's found it on the screen, then I'm sure the microphone will go live and she'll find it. I mean, certainly it's, I mean, the life expectancy figures, I think, have been commented on nationally. So I mean, you're absolutely right. It's fascinating actually seeing the local analysis of what does that actually mean, certainly in relation, I suspect, to deprivation, areas of deprivation, and also different community groups, and seeing what the local effects they are. Victoria, have you managed to find the data yet, or are you still frantically?
Of course, the website's decided to go down, but if you bear with
Okay, perfect moment. I had a moment this morning where my laptop decided to do a critical update just at the moment when I desperately needed to contact you, and so I know the frustration and the feeling. Look, we'll come back to that. I think it is a point that we're going to have to watch, I think, over the next few years as some of the stats start to appear within some of the sort of the wider information on rates that we have been probably quite okay with for a number of years, but suddenly start looking worrying. Right, I'm going to come in with Mr. King at this point, then Mr. Harrison. Anyone else with hands up? Otherwise, you don't get the opportunity to put your hands up. Mr. Charlesworth, you're our last person, Mr. Charlesworth. Okay, so we start off with Mr. King, then Mr. Harrison, and then finally with Mr. Charlesworth.
Okay, thank you, Chairman. Thanks for the report. I think this report is kind of related to the previous item in many ways. Really, you're just reflecting what's happened and what's not happening, and what I think is concerning. From just picking up the first point that you made about the data, yes, I think it would be extremely helpful to have the Leicestershire only data, but in comparison to the wider data, I think it's incredibly important to see this in context of what is actually happening across the whole of the system, which we're not seeing at the moment because we're just looking at Leicestershire and Rutland. I think we actually, and I know we're not looking at that because this is only a Leicestershire committee, and that will be a matter. I do think in order to understand what you're presenting to us, we need to understand what's happening in, and colleagues will know what I'm going to say, the inner donut of Leicester, of the health system, because that's really important. But looking at all the measures, they are poor. It is deeply concerning. And I know you're not here to tell us what they're doing about it, but I think these are the questions we need to be asking: is what is the healthcare system in LLR doing to sort some of these problems out too sweet? Because if you're having to wait excessively long time to get a cancer diagnosis or get cancer treatment, your initial primary cancer treatment, then your prognosis, your outcome is going to be a lot worse. The potential for you having a successful treatment or going into remission, all of that stuff, the medical people here will understand that better than I do, is reduced quite considerably. And so over a period of time, I just wonder, just picking up what the chair alluded to slightly, I just wonder over a period of time, are we then going to be expecting to see increased rates of death from some of these conditions like cancer and other emergency treatments, which are taking longer to get access to? And is that going to be, it's the unintended consequences, isn't it? But the outcome of that is likely to be increased demand on social care, on things like that, because people are going to need more support than they would have done otherwise if they had got access earlier. So I'm just wondering if there's any work to be done, or is it too early to do that sort of work, to look at forecasting what the impact might or might not be, particularly on the council finances, thinking of that, because that's quite important.
So I absolutely can pick up on some of that. So there is a integrated care board cancer system working group. They've just set up a quality and performance subgroup to look at some of the quality issues. It's absolutely being reviewed in terms of how many patients are waiting over 62 days and even over 104 days. We know that our biggest issue is in urology, and there is a whole action plan around what is going to be put in place there, which I'm sure colleagues from the Cancer Design Group could come and kind of speak to you around. I think it's also worth saying there are a number of harm reviews that are always being undertaken. So patient lists are being undertaken, reviews are being undertaken weekly, and a harm review has just been looked at, certainly from a UHL perspective, and we'll be coming to the system quality group this month around what are we finding from a cancer perspective. Again, the requirements there are from a physical harm perspective, not from a mental health. We recognise that's a gap at the moment. But in terms of the physical harm, we have absolutely looked at that from a UHL point of view. I recognise patients go elsewhere, but obviously we are the lead commissioner for UHL, and so we're looking into that. In terms of rates from death, again, we're constantly looking at the sort of mortality reviews coming through, and there's pieces of work going on both from a system and acute trusts around that. I'm not sure I could give you the feedback around that. I'm sure someone else in the room might be better placed to do that than I will. But I do agree when you say, let's look at some of this and how we compare to city. Equally, it's worth saying, what's the plan and how are we going to ensure there's some equity there? I can say that certainly for the dementia diagnosis rate, city is one of the areas is actually doing significantly better than county at the moment for dementia. So maybe there's a bit of learning to be done there. 104-week waits, we've broken some of that down by postcode and ethnicity to try and look at where we've got our biggest issues in the system, so we can take that forward into the next paper.
Thank you very much. I think Victoria is about 20 foot tall behind you, is the person you were referring to when there's somebody else in the room. Victoria, do you want to come back in with your stats?
Yes, they finally loaded. So for the city, the life expectancy for both males and females decreased by 0.7. And then looking at the healthy life expectancy in the city, males decreased by 0.7 again. And then the healthy life expectancy for females for the city actually increased slightly by 0.3.
There you go, Mike is wrong. There you go. Well, up to a degree, but it is worth noting these things when they happen because they're so rare. Can I just ask Louise to come in at this point? Mrs. Richardson, rather, sorry, and then I'll come back to you, Mr. King.
Yeah, you just mentioned in your update about the differences between the two East and West CCGs, and I've noticed, you know, as Councillor King said, you know, some of the parameters are poor. But I have noticed that there are a couple in there that have what I consider quite a difference from that. So I would be interested to see whether it's a common thing across, whether it's physically getting to hospitals or whatever, or whether there's something within the system that is causing some sort of block there, please.
I think that's something that we could break down some of the indicators against. Again, I would need to speak to colleagues depending on certain areas in terms of where it is, if it's terms of patient's choice and where it is they're actually seeking their treatment. Is it they're going into Leicester or they're going outside of the Leicestershire area, for example? But yeah, I'll make a note of that so we can pick that up for you. Thank you.
Thank you very much. Mr. King, do you want to briefly come back and then we'll go on to Mr. Harrison?
Yeah, just as a quick thing, what Mrs. Richardson just said, that actually was reported in, I think, the Health and Wellbeing Board about 3 years ago, that differential between East and West. So it's not a new thing. That's all I was going to say. So the only point, there was a point I wanted to come back on, and I've now forgotten it, so that's not terribly helpful.
We'll move on in that case.
Yes.
You were having a senior moment. We all have them, Mr. King.
Oh no, it was right. Yes, that's it. You triggered that now. Right. So today, the Office of National Statistics this morning released its population demographics by lower, medium, middle output, and all the rest of it. And so I presume we're going to kind of populate all your data now with all that new up-to-date population. It's quite interesting because in the kind of more of the county area, certainly the east and south of the county, the average age, the median age of a resident is in the mid to late 40s, but in Charnwood, it's in the sort of mid 30s. Yes, I know, and that's really what. And in the city, it's even younger. It's just over 30. So I think there is some issues with the kind of the population demography that maybe is driving some of those things. But then that I think we need to, the health care providers obviously need to update and refresh their strategies in light of the up-to-date demographics, because I think there is quite some huge trends that are going on at the moment in terms of that older people living out in the county, basically. Thank you, Chairman.
That's okay, Mr. King. Mr. Harrison, do you want to go next?
Yes, thank you very much, Mr. Chairman. I'd like to talk about the dementia element that you've got. Obviously, one of the main causes now stated by a team of scientists in NHS in London quite recently made a declaration that they were pretty certain dementia started with a chemical called PM 2.5. It's thinner than your hair and it's easy to digest, but it goes into the bloodstream. And obviously dementia and vascular dementia is really the bit where it seems to really thrive dramatically. So if it goes through the blood, it then affects the brain cell, it kills brain cells, and then obviously that's the whole onset of the whole thing coming forward. DEFRA now are starting next October, are making it compulsory for district councils to measure PM 2.5. They've known about it for a long time. They just go to simple old knocks. But now it is serious, because the stats a year or two back was about 350 deaths in Leicestershire, with regarding this is what the formula dictates, was the level of deaths attributed to dementia. So it has become really uplifted and upgraded, so there will be targeted, and obviously in time it will happen, and we've got lots of local authorities on now vegetable oil running the vehicles, but PM 2.5 comes from the tyres and also from the braking system. So, you know, you resolve one, but you've still got two more sort of hurdles to jump. But it is serious, and it's obviously expressed in figures across the country. So I'm pleased you're picking up on that, and hopefully once there is proper measuring, there can be an element of protection, but it's not going to be easy to mitigate because you can't just ban lorries. You know, how do we go about it? It's once we understand and got statistics, then how we're going to deploy them in a proper, professional, meaningful way. So we're probably on a 10-year journey, I'd have thought, before we can sort of arrest one of the main exponents, parts of this, components of PM 2.5. But at least you are in the game now, collecting stats, and you know all of this will be helpful in due course. Thank you very much, Mr. Chairman.
Thank you very much, Mr. Harrison. I mean, because I think that's a particle size, isn't it? And there are certain elements that are so it's a measurement of the actual size of a particle, and so small that actually it has the ability to travel sort of beyond places that and any component can be that size, but some are more likely to be that size, I think, than others. So it's yeah, the more we actually understand about these things, I think the more interesting and challenging it is to try and actually work out some of the solutions. But I have a particular constituent or resident who is a former university lecturer who has educated me over a number of years about particles and transmissions, and it is eye-opening. Very interesting, very interesting. Thank you very much for that. Mr. Charlesworth, do you want to go next?
Thank you, Chair. It might be a little naive question, but I'm looking at page 45 on modern.gov about the total number of Leicestershire and Rutland patients waiting at all providers, and it's over 90,000. Does the NHS make use of the private sector in any respect in trying to deal with this backlog? I mean, I had a problem with my hip recently. I didn't have any insurance and it was self-funded, but I had the money to do that, to get the scan and the treatment and the process. And I was fortunate. I don't, you know, kid me not, that I was fortunate enough to do that. But does the NHS tap in? Because it seems that if you go down the private route, you can get things done fairly quickly. I'm not a socialist. I'm not saying it's wrong. But it just seems there's capacity there where there isn't in the NHS. And you mentioned that dementia was dealt with better in the city in diagnosis terms. Do we, once you're in the system with UHL or whatever, are you able to actually go be signposted to another provider that actually has a good performance record in a particular subject, be it cancer diagnosis or therapy or whatever? Do patients have that opportunity to go to Lincoln, to Birmingham, Liverpool, wherever, where they're doing a particular thing well? Do they have the chance to do that?
Yeah, absolutely. So I think there's two things there. So the first is patients are offered the choice. One of the things we do look at is all of our out-of-county providers, NHS providers, and how they're performing. And that information is shared with our primary care colleagues, so they will know perhaps where waits are shorter. If they're shorter for cancer treatment at Kettering and the patient is happy to travel, for example, is that an option available to them? And then I think we've also got the question about the private sector. We absolutely are using the independent sector at the moment for support with NHS work. We've got a whole plan of action around which procedures and what their capability is and what their waiting times are. And so we have found that a number of patients have been referred to Nuffield or Spire or Ramsey Healthcare, for example. We are using that resource available to try and make sure that we work to, you know, the right care in the right place for that patient. So that is absolutely a dialogue that's taking place. Earlier on this year, we called a whole number of patients who were waiting significant amounts of time for their treatment to ask would you still like the treatment? Sometimes things change and people have gone privately or don't require it, so we can make sure our numbers are up to date. Or would you actually like to go somewhere that isn't UHL? And would that be available to you, whether that's the independent sector or another NHS trust? And that was really helpful to us to be able to kind of support people with their own experience and getting that treatment to the best of their ability. Sometimes it obviously depends what it is, and people might have a relationship with a certain NHS provider or a certain healthcare professional, but other times people are generally quite open to being able to move around the system. So we will make use of those providers, and there is a whole plan in place around kind of mutual aid arrangements that we've got in place.
Just a quick one, Chair. Are you able to look at other countries of how their health service is performing? Because we've struggled when we've come out of COVID, and there was a lady on Radio 4 as I was driving here, Richardson. No, not that one. No, somebody much higher up the chain. No. She was ahead of something. Sorry, I can't remember the lady's name, but she made the point that the real issue is vacancies and staff. It wasn't particularly money, although the 145 billion I understand is being protected, although she did say it's still 7 billion short of where it should be. But she briefly touched on how other health services across Europe hadn't struggled as much as we had coming out of COVID. And I just wonder how France, Germany have dealt with it in a way that we haven't. I know the NHS is a big cumbersome beast, and like a supertanker, to turn it takes an awful lot of time, and perhaps it's a victim of its own success in some respects. But I just wonder how we compared with other countries around the world.
Without cutting through for the answer, possibly, I suspect that's probably for the Health Select Committee at House of Commons, not necessarily Leicestershire, because we have our own Mrs. Richardson, who, of course, can answer all these questions. But unless Hannah has a miraculous answer, I suspect it probably is a national question, not a county one.
Yeah, I can say that we've got workforce plans in place. We've got something that, you know, a whole workforce strategy within the ICB at the moment, and we are looking at things like international recruitment as part of that, and how we utilize our workforce, how we upskill them, how we use different members of staff and that sort of thing. But I couldn't tell you how we compared, I suppose, to other countries at this point in time. Whether there is somebody else who might be able to do that, I'm sure, but from a performance perspective, it's not something I've looked at.
If it helps, Mr. Charlesworth, I think Mike wants to come in at this point. He may have a point about. It was Amanda Pritchard you were going to say, I think.
Well, yeah, that was the head of the NHS. And I was going to say, in terms of OECD figures, I thought we never fare as high up the list of good health outcomes as we should do, given our relative affluence. There you go. But that's entirely because we don't invest enough in public health, not the NHS.
Okay, we're now going to get extremely parochial about investment.
So we couldn't ask Matt Hancock then?
I do not have any questions at all that I wish to address to anyone else outside of this room. Okay, right. Thank you very much, Mr. Charlesworth. So, look, we haven't got any further questions. Thank you very much, Hannah. Thank you very much, Andy. Thank you very much, Mike, for all of that. We're now moving on to, we'll be very brief, so by all means, please stay with us for another 30 seconds. We'll now move on to item 12, dates of future meetings. Those are listed out, scheduled out. Our next meeting is 18th of January next year, so happy Christmas and happy New Year. Until the next meeting, that will also be at 2 p.m. Item 13, any other business that anyone has raised with me as being urgent? No items have been raised. So with that, I'm officially declaring the meeting closed. Thank you very much. Thank you very much to everyone. Thank you.